Okay, so we're back. So we were talking about the approach of the levels of to assessment and stuff like this. It's very interesting. And again, so I may be a little bit, because I'm still learning that stuff, but this is what I'm going to be doing now. It is very interesting. So let's say we have this person, okay? So I do my Vindicate self, I get my list. I do my assessment to make sure that I get kind of differential of whatever. And then from there I do my two lists, 1 and 1E, which is the emergency one. And from there I decide to, am I going to rule in or rule out where I'm going to rule. And then I choose a test depending on like how specific or how sensitive it is. And then from there I'm going to ask myself, do the likeliness, so based on the sign and symptom, the epidemiology, so what the subacute, so is it subacute, acute, and all the time period and what the story of the person got from my assessment, how much do I think this person is likely to have a disease? So let's go take our gentleman, comes 65-year-old, and so we'll take two patients, A and B. So a 45-year-old man that comes in and a 65-year-old man that comes in. 65, so that's patient B. So let's go with patient A first. So patient A is a gentleman, comes here, back pain, and no hematuria. He says that he was working hard this weekend in the backyard, and I think he's straining his back and stuff. Patient B is 65-year-old, history of hypertension, cardiac history, diabetes, you know, like that. And he comes again with his back pain. And his back pain is, so it's, he says maybe sometimes he does have chest pain, and it's kind of radiating his back, and felt like it was a sudden, and it just happened about 2 or 3 hours ago, and you do your assessment. So you look at your Vindicate, and in the back pain, you would have in the vascular part, maybe we're going to get like a whole bunch of different, so muscular, skeletal, obviously, that would be like the trauma part, so that would be like most likely in your patient A would be mostly in 1A, but in both in 1E would be a chance that you could have a dissection. So in the first patient, it's kind of low on our list. It's there because I need to rule it out, but it's low on my list, versus the other person with hypertension, has a lot of signs and symptoms of it, and increase. So let's say on our patient A, so on patient A, I'll say that the section is maybe 5 out of 10 because he had family history or history of Marfan syndromes or something like that, and it's 5 out of 10. Patient B, he's got hypertension, he's got a lot of signs and symptoms of it, so I think it's going to be 8 out of 10. So here's the cool part where all this blah blah that I'm doing is useful. So okay, so we're just going to consult on the section and stuff. So like I was saying, this made equation, but also you can find them online. And basically what you want is a sensitivity specificity calculator. So you can get it online as well, but I like it that I can have it on my phone. So what you do, as you can see, this is pretty much like the screen that I get. And this is how I got those numbers. So on the sections, a lot of people like take the blood pressure on both arms. Here's one, this is where I'm explaining what I'm talking about, is important because sometimes we're pushed to do stuff, but we don't quite understand why we're doing that, or should we even do it, or if it comes back positive, was it like a positive trope, does that mean anything? And this is where those things kind of help. And that's what I was saying. So if I get those two gentlemen, and let's say their boat came one after the other. One is 11 to be seen, and the other one is 14 to be seen. So, okay, so both bilateral. So we've always been told, let's do a blood pressure on both arms. And we're looking for 20 of difference, right? Well, the BP has about less than 20%. Less than 20%. So that means out of 10 people, 8 of them won't have it. Only 2 people. Yeah, out of 100%. So out of 10 people, only 2 would have it. Or if you prefer, out of 100 people, 20 people may have it, will have it, but 80 people won't have it. So it's less than 20%. So if it's there, sure, it can help me. But if it's not there, it doesn't really help me much because, yeah, if it's not there, I still have a chance of being 8 times wrong. So there's so there could be like 80 people that gonna be still have the disease, and but I would miss them. So not very reliable. Radiation. We were talking before. Somebody that says, "Oh, it radiates to my neck versus radiating to my back." If it doesn't radiate to the neck, but it radiates to the back, it won't be present. So it won't be there in only 5 to 10% of the time. So basically that means that 90% of the time, so 9 out of 10 people will have it. So it seems like to me, assessment-wise, I will focus more on asking that question than taking blood pressure on both arms. Doesn't mean that I won't take it, but if it is there, or if it's not there, but I have my radiation in the back, this person will be higher on my list than if it's not. So I just wanted to show that because a lot of time we don't kind of ask that question, but we focus a lot on the BP, and yet it's totally the opposite. Is that if it says it's radiating to the back and it's that tearing stuff, it's almost 90% chance that it is a dissection, especially if you suspect it. Then if I have a difference in the blood pressure on both arms. So you get more money, basically more bang for your buck, if you do a proper questionnaire than if you do blood pressure on both arms. Doesn't mean you shouldn't do it, but if I have to choose one or the other, I'm going to choose my assessment on asking for the back and stuff like that. So where does that calculation comes true though? This is where it is. So there's studies now that are showing that if you do a D-dimer, on someone that you suspect to having a dissection, so that means you don't do a CT, but you do a D-dimer instead. The specificity, so again, the spin, so to spin out, is very low, but the sensitivity is very high. So, from the studies that I've shown is that the specificity is only 56%. So that means that to rule it in, it's not very good. Because spin, right, to rule in the disease, but to rule out the disease, it's very high. It's 95% of the time, I think. Actually, 98%, yeah. So the sensitivity, so the sensitivity, so to rule out the disease, so SNOUT, is 98% of the time, and the specificity is 56% of the time. So what does that mean? Because, I mean, we're throwing numbers and stuff like that. So remember patient A. So remember patient A. Oops. That we said that maybe we thought that because he has some history and everything, he was a 5 out of 10. But this is what it helps, and this is the beauty of that system. That's why I'm going to pretty much do it on all my patients now. So what you do is, if you have this apps, the prevalence, this is what it becomes. So you change your, on scale of 1 to 10, you change that in a percentage. So I think that if there's 5%, 5 out of 10 chance that this person has, that means the prevalence of 50%. So what I do is I put 50% there. And then I put those numbers. So that means that you need to know the test that you're going to send. What is the specificity and the sensitivity? So the sensitivity was 98%. The specificity was 56%. So the numbers that I get is this here. So I get positive and negative. It's 69 and 96 negative. And that is patient B, which we said because of his history and everything, it probably was an 8 out of 10 chance that you could have the problem. We put him as an 8, so that means become 80%. And the numbers are 89 and 87. So what does that mean? Here's what it means. This is where it's so cool. And this is where, like, you know, like, should I send something or not, or should I send this person? So basically, gentleman that came, and I thought that he had 50% chance of not having a back pain. And he was like a 5 out of 10 out of it. Because the test, so the D, we're not only talking about D-dimer, we're not talking about the other motility and stuff. If I said, so I'm at 50%, so I'm not quite sure, I'm like, I'm 50-50, so that means like he could have it, but he could not have it. So I want to be sure before I send him home, because again, it's a high risk things to miss. Let's say I do send a D-dimer. I send a D-dimer on this gentleman, and it comes back negative. If the D-dimer, because of his complaint and everything, comes back negative, based on the specificity and sensitivity and the calculation we did, I'm 96% sure now that he do not has a dissection. 96%. So that's pretty much almost 100% sure that this person can go home with no other, doesn't have a dissection. That's only to do a D-dimer. So if I have a high suspicion on someone, or a low suspicion on someone, but I still want to rule it out because there's in the history there's something that it could have happened, I could have sent this blood test that costs pretty much nothing, and I have if the test comes back negative, positive though, then it increased my stuff at 69%. So that means that if the test comes back positive, then I'm like, whoa, I was at 5 out of 10 chance that this guy would not have, that patient A was not have a dissection, but now I'm like at 70%. So the test came back positive, so I'm going to do other investigation. Then again, now you do the other calculation. Versus the same test, that D-dimer, in the person that we were seeing for 80%, it goes to 87 or 89. So basically, it doesn't help me at all. So if I have someone that I really think that it has like is an 8% chance, then probably a CT would be more specific for patient B, and a D-dimer could be useful for patient A. All this from a quick calculation that I can do on my phone, and I can plug those numbers in there. So I thought it was very cool to have the tools there and to use that, and so I wanted to share that with you, because now suddenly I can approach, it helps us decide where we're going to send the patient, and if the test comes back positive as well or negative, it tells us, should we continue more investigation, or should we stop our investigation and be pretty sure that this person can go home or something like that. So I thought hopefully that was helpful, and I'll talk to you soon.